Thank you very much. Really nice to hear there from a couple of the patients at GOSH. And also, I thought I'd read out that during this session where we're aware we've had some of our YPAG members online, we've had messages from one of them in particular, Mutazim, who's one of the brothers of a GOSH patient, and he's a member of our YPAG group and worked with us for a few years now. And he sent a message to say, I really enjoyed hearing about the stem cell session and regenerative medicine earlier. And it's great to hear the work of YPAG being mentioned. So we just thought we'd share that some of our young people are also really enjoying this session. Thank you for joining us. Okay, we're going to move on to the final session of the day now, which is a final research hospital session focused on COVID-19, which has been so important for all of us. So I'm going to hand over to Dr. Jenny Rivers, who's our Deputy Director of Research and Innovation at GOSH, to chair this final session.
Thank you very much, Laura, and good afternoon, everybody. I'm absolutely delighted to chair the final research hospital session. As Laura said, we're going to focus specifically on our response to COVID-19. In particular, I'm delighted to share with you 3 examples, which I think will really highlight what Matt talked about at the beginning of the session in terms of how research hospital infrastructure and having that in place allows us to be flexible and really achieve that vision to improve outcomes for our patients and families. So the first talk is from Professor Judy Brewer, who I've heard being mentioned as the Queen of Virology. And Judy is the Chief Investigator of the COVID-19 Genomics UK Consortium. And she's going to talk to us about the impact of integrating real-time rapid COVID-19 genomic sequencing in the NHS to understand and prevent virus transmission. So thank you very much, Judy.
Thank you very much for inviting me to give this presentation to the BRC symposium. I'm going to talk to you about the UK Hospital Onset COVID infection study. The rationale for the study is that we know that hospital-acquired infections cost the UK £1 billion per annum. And during the height of the first wave of the SARS-CoV-2 pandemic, we know that hospital-acquired infections accounted for 11% of inpatients and a considerable amount of morbidity and mortality. In the past, including at Great Ormond Street, we have used sequencing of viruses, and others have too, to show that this better identifies the sources of hospital infection and transmission routes than just infection prevention and control methods alone. But sequencing is almost always retrospective, so it doesn't affect the immediate actions of the team. It's more used for audit and root analysis of causes of outbreaks. However, during the SARS-CoV-2 pandemic in the first wave, various hospitals started to do rapid sequencing, and they reported that it did actually improve the management of hospital outbreaks. However, this was not measured in any way. It was just an impression. It was not clear that this could be done at any time beyond centres of excellence, and it was not clear how cost-effective this would be. So to investigate this, we set up COG-HOKI. It was an urgent public health supported study, and it involved recruiting 14 geographically distributed hospitals across the UK, all of whom had sequencing centres attached to them, which were already carrying out sequencing of SARS-CoV-2 to inform the public health management that was going on at the time. These sites sequenced all the SARS-CoV-2 positive inpatients and healthcare workers over about a 3-month period, and that amounted to, in the end, over 30,000 patients, of whom 2,000 had acquired their infections in hospital. The sequence data, patient metadata, and community sequences were integrated into a probability model, which was known as the sequence reporting tool, and this took all the data together and used it to identify which patients had acquired their infections in hospital, the HOKI cases, any other infections that were likely to be linked to this person who had acquired their infection in hospital, and then to report the results on a simple form that could easily be understood by the infection prevention control teams. The impact of the time to sequencing on the infection prevention control activity was analysed. We also carried out qualitative evaluation of what worked, what did not work, why it worked or did not, and how it could be fixed. And we did a health economic study. So the results were that all sites found the Hoki study to be immensely challenging. This was at the height of the Alpha variant sweeping through the UK. IPC teams were already doing the maximum they could. We didn't have time to train people properly, and we also discovered that the SRT needed to be better integrated with patient and sequence data. So it was not an ideal study. However, despite this, we found that in 77 to 90% of cases, the sites found the sequence reports useful. And at the shorter the turnaround time to receiving that report, the higher the percentage of people found it useful. The sequence reporting tool was better able to identify those infections that were acquired in hospital and distinguish them from those that were acquired in the community, particularly with those that were acquired very shortly after being admitted in the first 7 days, the so-called indeterminate cases. And in fact, the SRT identified over 90% of the Hokis versus about 66% by the infection prevention control teams alone. A per protocol analysis of around half of the Hoki cases showed that if the time to getting the sequencing report was short, with a turnaround time of less than 5 days, this actually changed infection prevention control management in about 20% of cases. So in conclusion, we have shown for the first time that if you sequence pathogens rapidly and return the results within, for example, 5 days to the infection prevention team, you can actually change their management. We've shown for the first time that a large proportion of people find these sequences to be extremely helpful. In this case, 89% of those who received a report within 5 days reported it as being useful. We estimated that sequencing pathogens locally to allow its use by hospital infection teams would cost about £10 more per sample than the current sending it away to more centralised sequencing centres. And the data we collected from the Hoki study provided us with a roadmap towards the potential for rolling out pathogen sequencing in the NHS. We now know the steps that we would need to take if this was to become more widely available. And one interesting additional impact is that as community sequencing is scaled back as the pandemic recedes, there will be a need for genomic surveillance, and it's possible that the routine hospital sequencing for infection prevention and control of epidemic pathogens such as SARS-CoV-2, but also influenza, RSV and norovirus could actually become the framework for genomic surveillance between pandemics. So I'd just like to end by thanking all those who made this study possible, the 14 sites who are listed here, the COG UK team who funded and supported the study, and the UCL team, including the GOSH BRC, who helped me set up the study and provided support for it as well. Thank you very much for your attention.
Thank you very much, Judy. A really fantastic example of research directly influencing clinical management. So next up, we have Giovanni Job, who is a member of our BRC junior faculty and a Catalyst Fellow. I know that you've been waiting patiently to hear more about his work on gastric organoids after Paolo whet our appetite earlier. So without further ado, Giovanni, I invite you to join us and to share your slides. Thank you.
Yeah. Hi. Let me share the screen. So let me put it in presentation mode. Okay, so thank you for having me this evening and giving me the opportunity to present the work we accomplished and we finalized in the past 2 years. And this is the work on SARS-CoV-2 infection and replication on human gastric organoids. So I was awarded in February 2019 with a Knowledge Transfer Scheme award from the BRC that allowed me to go for 1 month in the Netherlands to work in Hans Clever's laboratory, the pioneer of the human organoids. I learned this technique and I was able to bring back this skill to our laboratory in ZCR, and I was then awarded with a Catalyst Fellowship from the BRC that supported with my salary for 2 years until May 2021. So the human organoids are three-dimensional cell aggregates that resemble the behavior of a human organ. They can be derived from many different organs, and they allow us to study how the cells of specific tissue behave in vitro. Therefore, we can use these organoids to model human disease and, for example, to do drug testing. Particularly, I focus my attention on human gastric organoids. These organoids are a very useful tool to describe for us researchers to help us to study the human stomach. During the early period of the pandemic, so in March 2020, we started to see in the hospital at Ghosh some gastrointestinal symptoms that were prevalent in the children. And these observations were reported in an early work published in Lancet. Considering that I already learned the technique of the human organoids and I was studying the human stomach in vitro, I was able to start straight away, directly in March 2020, to study to model how the SARS-CoV-2 could infect the human stomach in order to describe how this virus can enter the gastrointestinal system. And we wonder, our key question was whether this infection was prevalent in the children compared to other stages of human development, such as the fetal stage or the adult stage. So this shows you how we started. First, we were able to get human biopsies from the human stomach. We isolated the gastric stem cells in order to generate the in vitro models that we called gastric organoids. We then decided to facilitate the possibility to infect these organoids by reverting the polarity of the cells. This means that we were able to revert the orientation of the cells in order to expose the apical part of the cells where the virus can attach in order to be able to infect these cells. So in this picture, you can see a human gastric organoid that is infected by the SARS-CoV-2, and in green, you can see the cells that are actually infected and they are dying. So we started by describing our model. So we needed to check whether the cells in different developmental stages were expressing the two receptors that allow the virus, the SARS-CoV-2 virus, to bind and enter the stomach. You can see in green and red that both of the two main receptors of the virus are present at any stage. So early fetal stage, pediatric stage, and adult stage. This picture here shows how the cells can actually be infected by the SARS-CoV-2, and they respond when the virus replicates by activating the programmed cell death. So our major result was when we did the comparative infection of all the stages of the human gastric organoids, and we could observe how the pediatric patients responded in a higher fashion to the infection compared to the adult counterpart and to the early fetal stages of the cells. We were also able to infect the human cells. So it means that still these cells are able to be infected. But in order to do so, we had to further differentiate the cells. So we had to induce a further maturation in the adult cell types in order to get infected by the virus. So this work was founded by the BRC. I obtained a research fund in June 2020, and this research fund allowed me to perform this research in the past 1.5 years. And we were able to successfully publish this work in a high impact factor journal in Nature Communication. The work was very positively received by the public. It had a high resonance, and it was picked up by many, like 13 news outlets. So we were very happy about the power of communication that we had thanks to the BRC. So the conclusions of this work are that actually children are more subject to gastrointestinal symptoms than adults, at least in our in vitro model. So we are able to infect more efficiently pediatric cells rather than adult and fetal cells. The other conclusion is that the gastric organoids are a very useful tool to study infection in a laboratory, and these organoids can be applied, for example, to test antiviral drugs. We are currently continuing our work, and we are analyzing how the SARS-CoV-2 is correlated to an infant disease such as the intestinal intussusception, and this work is currently in revision in pediatrics. We are further contributing to the literature by describing on how the human organoids can be effectively applied to the regenerative therapies in children, and this review is currently in revision in the Lancet. So I would like to thank you for your attention.
Thank you very much, Giovanni. If you could stop sharing, that would be wonderful. Thank you. Really fascinating work. Lovely to hear. Okay, so without further ado, I'd like to introduce our last speaker, and this is Helen Ashton. Helen is an advanced nurse practitioner that works with us in R&I and research, and she's going to talk to us about her role and the developing role of the advanced nurse practitioner during COVID-19. So Helen, if you could start your presentation, thank you.
Hello, my name's Helen Ashton, and I'm one of the advanced nurse practitioners working at Great Ormond Street NIHR Clinical Research Facility. I was very fortunate to be the first research AMP at GOSH, and my training and now qualified role is supported by the BRC funding we receive. I'm going to talk to you today about my role, the impact of COVID on the running of clinical trials at GOSH, and the future development of the AMP role in research. Advanced nurse practitioner roles have been in the NHS for over 30 years, however they are a very new role in research, with 1 or 2 exceptions. Alongside being the first research AMP at GOSH, I was only the second research AMP in paediatrics in the UK, so it is a very innovative and exciting role. My experience in the qualified role has been somewhat different to what it may have been, having qualified just prior to the pandemic. AMP training is a master's level training completed by an experienced nurse that allows you to work in extended clinical roles in your specialist area. This role in research can involve many different tasks, but is quite different from other AMP roles. The main focus of my role is early phase, high intensity studies. These are often looking at first in human trials for children with life-limiting conditions that have no standard treatments. I'm delegated on trial logs to be a sub-investigator alongside the research fellows that I work with. This role is to support the principal investigators with the clinical delivery of the trials, providing medical cover on the CRF for research participants. AMPs assess, diagnose, treat and refer patients. We take complex medical histories, carry out physical examinations of patients, assess eligibility of children for trials, and take consent for some studies. I have trained in some advanced clinical skills, for example, intrathecal drug administration. I carry out non-medical prescribing and radiological requesting. I also help provide provision for continuity of care, helping with the transition of new drugs into the clinical service. Day to day, I provide leadership to support both the clinical and non-clinical teams. This can help support their professional development as well as provide peer support. I work on SOPs, guidelines, and policies. It isn't always an interesting role, and every day is different. As well as the personal challenges of being in a brand new role during a global pandemic, there were many other challenges presented to us as a research facility. When the pandemic began, all clinical trials were categorized to understand what research could and couldn't be paused. Studies that were classed as essential continued, but without the previous medical support due to redeployments and off-site working. There was a requirement to continue delivering high-intensity, early-phase clinical trials to children when it was their only treatment option. AMPs being able to step into roles previously carried out by consultants or clinical fellows enabled these clinical trials into rare paediatric conditions to continue without any pause or disruption to patient schedules or treatments. Many of the essential studies I worked on involve weekly infusions using intracerebroventricular or intrathecal devices. Previously, only doctors had carried out these treatments, but already being involved in the trials and knowing the families well made this an easy transition for myself to do this work. The numbers of patients involved was quite small, but the significance to the individual families of continuing on their medication was immeasurable. Many CRF research nurses and non-clinical staff were involved in the rapid setup and delivery of urgent public health COVID-19 trials, as well as in the rollout of vaccines for all staff members. Many were redeployed to busy clinical areas and even other hospitals. We learnt to work in new innovative ways, for example, remote consent, IMP delivery and administration at home, as well as conducting virtual trial visits. Many of these new ways of working continue now and are seen as positive changes for patient experience. As with any new innovative role, there are many future developments being worked on. Along with the other research AMPs across the country, a national forum was created in 2018, and even now this is a small group of around 8 qualified members, but with more in training. We now meet virtually 4 times a year to support each other in the development of our individual roles, but also to work on national developments of the role. I continue to develop my portfolio of clinical trials, undertaking the role of sub-investigator and principal investigator. I'll continue to educate key stakeholders around the paediatric research AMP role and its benefits, continue to challenge sponsors who limit the roles delegated to AMPs working in clinical research, and continue to collate and analyse qualitative and quantitative data to support the success of the AMP role. Recent meetings with Ruth Endicott of the NIHR help promote and develop this role. Overall, we aim to lead the way for AMPs in research and provide education about our role, doing presentations such as this, as well as publications and other conferences. We hope this will develop into a new career pathway for paediatric research nurses. Thank you. Happy to take any questions.